Hi, I'm Dr. Ashley Fuller.
And I'm Dr. Meredith McClure.
And this is Labia Logic,
the podcast that's all vulva, no filter.
We're here to talk about all the stuff your doctor rushed through, the questions you've been too embarrassed to ask, and the sex ed that barely mentioned the vulva.
Because too many people are suffering in silence with painful sex, menopause misery, and vulvar issues no one talks about.
No shame, no stigma, just real talk, real answers, and the education you should have gotten in the first place. All right, welcome back to Labia Logic. We are excited to be back today. We're going to take a deep dive into lichen sclerosis and lichen planus. The lichen strikes back.
I love it.
Yeah. So we want to talk about these conditions because they're actually fairly common. They're things that we see fairly frequently in our vulvar practices. And they're things where patients often really struggle to find a diagnosis or to get treated effectively. And so we really want to kind of take a deep dive. We've mentioned it in prior podcasts, but we really want to kind of take a deep dive into what are these conditions? How do you get diagnosed? What symptoms do you have? And how do we treat it?
When people hear the word lichen, just to clarify what that means, because they think it's, a fungus, or they're thinking of a mold or something along those lines. Lichen just means thickening. And so when they're talking about this in some of these diagnoses, it could be a thickening, like a visual, like you could see a thickening or feel a thickening of your skin and your vulva. But really with these two, it's not as much an appearance of thickening per se. Could a little bit sometimes, but it's really, they're talking about what it looks like under a microscope. So it's something the pathologist who's looking at these specimens under a microscope might see, where it's thickening in areas in the tissue itself, microscopically, that we see that. So just to kind of clarify, because I think that word kind of scares people sometimes, don't you?
Well, right. I mean, you think of lichenification. So think about moss growing on trees or tree bark. It feels like something's growing on it. So this is not something we're going to get like something growing necessarily like that shouldn't be there. This is skin changes. They actually look fairly thin when you actually look at them. So people often think, oh, my skin is thinning, but there's scarring underneath that under the microscope is actually thick and is probably some of the reasons for having these conditions. So let's jump into what these are. So lichen sclerosis is, a chronic inflammatory dermatoses of the vulva. It's usually on the vulva. You can get it around the perianal area also. You can get it other places on your skin. I've had patients who've had it on their abdomen, underneath their breasts. It looks a little bit different in those areas. I'm not a general physician, so I'm not used to looking at skin everywhere. I'm not a dermatologist. It is something where that causes some whitening of the skin. So you can notice it in those areas. It is fairly prevalent. I mean, like they say, like about 1 in 60 women. It's not something I see uncommonly. I mean, yes, I'm a vulvar specialist, but it's definitely something even in just regular practice, I think is something that is more common than people would think it would be, especially since most people have never heard of it until they get diagnosed.
Yeah, you hear that it's so rare, or like rare disease day, lichen sclerosis. And I think it's quoted as being rare, but I think it's more because it's just completely underdiagnosed and underrecognized. And we see that as patients struggled for diagnosis. They go like 5-10 years before they even get a diagnosis for many.
Yep, definitely. And there seems to be some hormonal component to it we don't completely understand. Kind of in all things, we need more research in these areas, in all things women's health, specifically this too. But we tend to see it more often in prepubertal girls and then postmenopausal women. Not only those, definitely see it in patients I definitely see it in 20 and 30-year-olds also. So definitely seems to be some hormonal component to it because of these kind of peaks in diagnosis around these times where we don't have estrogen in our bodies.
Yeah. Another time that you can sometimes see it is actually postpartum. If all of a sudden you've had a baby and maybe you're lactating and you have itching, maybe think you have a yeast infection, it's tearing, it's hurting if you have sex, things like that. Someone should look at your vulva. We do see it for some patients will manifest in the postpartum period. So yeah, there's possibly a hormonal component. Sometimes we see patients and there isn't really a hormonal component. It's kind of the great unknown that we don't totally understand why this totally happens in some people and doesn't in others. It's to be determined, and hopefully in time we'll start to figure out that.
We think it's autoimmune in nature. I always tell patients that if they already have an autoimmune disorder that is more likely they'll have this. So a lot of my patients have a thyroid disorder with it. That's a really common one, hypothyroidism.
Vitiligo.
And vitiligo.
Mm-hmm.
Yep. But definitely I see other ones, Sjogren's. I mean, any autoimmune disorder that you may have would put you at higher risk for having this because we do think there's some autoimmune component to it. And then there's also some genetic predisposition. Sometimes I have patients that tell me, oh, now that you've told me I have this, I talked to my mom and she told me she has this too. But it's just not something that we talk about all that often unless you're us. So I think that people don't always realize it may run in their families. But definitely we don't completely understand all the background of it because, sometimes we know that there's the hormone component to it also. So there's multiple etiologies of it.
Yeah. And it's definitely not an infection of any kind. You didn't catch it from someone. And I feel like a lot of women, when they have things going on in their vulva, they want to clean it all the time because they feel like it's a dirty thing. And it's not related to what products you're using or not cleaning it well enough. And we need to kind of recognize that. We've kind of talked about why LS happens. What would you say like patients will come in complaining of? Like someone's like, I'm having an issue in my vulva. Is it lichen sclerosis? What are things that they might be complaining about of?
And one of the most common things is itch. So that's one of the biggest things is itch. And it may be all over the vulva, it may be in one specific place, but itch is the most common thing I see. But sometimes people will say, well, I looked down there and things just look kind of weird. We recommend on this podcast, if you have a vulva, that you look at it once a month, use a hand mirror, look at it, know your body. They may notice things have changed, or they may be having pain with sex and they aren't really having actual symptoms of itching. In fact, about 10% of patients won't have symptoms at all with this. So sometimes people actually don't get diagnosed until they just have an exam and someone tells them. And I actually find that not infrequently also.
Yeah, even just tearing with everyday life.
Yeah.
It could be I'm working out, I'm bent over to pick something up, and then I had noticed a tear in my vulva, or I went to the bathroom and it burned when I went to the bathroom. Like if you have urine that actually hits an open cut on your vulva, it will burn. So sometimes people complain of that kind of stuff, and it can actually start to impact their daily life and quality of life. Like it's hard to wipe when I go to the bathroom. I can't wear certain clothes. You'll kind of hear things like that, I think, as well.
Oftentimes people are noticing a change and they can't figure out what exactly is going on.
Yeah. Even it feels different.
Things feel different.
Drier, things like that.
Things could start looking different too. I mentioned that there's some whitening of the skin. It kind of looks thin or crinkled. Talk about the cigarette paper look to it, which I don't know, it just looks white and not like a skin color white, like a sheet white, like a sheet of paper white. So it just looks like that skin is out of place. But also sometimes people will also notice some architectural changes. So we've talked in this podcast before about vulvar anatomy. You have your labia majora, which are our hair-bearing areas, our labia minora, which are the smaller lips, the hood of the clitoris. What we see in lichen sclerosis is usually there is some resorption of the labia minora where they start to kind of get smaller and they may even disappear completely in this disorder. And then there's oftentimes some kind of phimosis or adhesion over that clitoral hood, which can make it hard to access the clitoris or could actually completely cover the clitoris. So patients sometimes notice I've lost my clitoris or, have itching, but my labia are gone. They used to be there. So those kind of changes too.
What we call scarring, which the lichen sclerosis, lichen is thickening, and then sclerosis means scarring. And the two dermatoses we're talking about today are the ones that will cause scarring in the vulva. And what we're talking about is that the anatomy is changing in the vulva. The labia minora specifically, kind of you imagine these little flaps, and they start to kind of evert a little bit to the lateral part of your vulva and kind of just start melting into the labia majora almost. It can be really subtle. And of course, we see this all the time. So you'll see sometimes these subtle little changes where you're like, I think this is starting, but it can kind of do that and resorb. But also sometimes they'll even kind of go towards the middle and fuse kind of even in the middle, like around the urethra there at the top of the vaginal opening. And that can cause even some urinary problems where all of a sudden your urine stream's going in weird directions, or maybe you're having sex and you're noticing some tearing up near your urethra or your clitoris. These are things that can happen. And then with that clitoral hood, which is, that kind of like a branch of the labia minora that goes up and over like at a big, upside down U, and it's a flap of skin that you should be able to retract over that head of the clitoris. It is our foreskin. It doesn't move anymore. And sometimes it completely covers the head of the clitoris, and that can create pain in the clitoris. It can decrease sensation. Maybe you're not having orgasms at all, or they're not near as intense as they were before. Present with, it's not really totally an abscess, but they just get this dead skin and things trapped underneath that clitoral hood, and they'll have like a big cyst that's filled with like mucus. It's super painful. I mean, and some people get diagnosed, I feel like, by that happening. And the reason this happens is that LS is extremely inflammatory, and this autoimmune nature of it, where it attacks this layer underneath your skin and it causes that scarring, and it's from inflammation in your skin. And that's why this starts happening. And that's also how we treat it, is to attack that inflammation.
With some of these labial changes, I do think there's this narrowing of the opening of the vagina, and that's why you start getting these tearing with sex. And so you can have tearing anteriorly, so up toward the urethra, or you can have narrowing posteriorly, or tearing posteriorly because of narrowing down there. Sometimes they can get like a posterior commiserate band, which is just a big word for like a tight band posteriorly. I see that more common in my lichen sclerosis patients also.
Mm-hmm. Yeah.
Can make sex very painful.
Yeah. And it can happen on the anus as well.
Yeah. We're going to talk about, the symptoms and things like that with this, but there are a lot of patients will say that it took them a long time to get diagnosed, that the diagnosis was really hard for them. The average 5 to 15 years to get diagnosed, which is terrible. This should be something you're having itching. Ideally, a clinician looks at your vulva and knows what they're looking at and gives you a diagnosis and gives you a treatment. But unfortunately, that's not how it generally happens. This is something that you can diagnose by looking. I diagnose this by looking all the time. So does Meredith. We were taught in residency that you should always biopsy it. I think one of the ways they made up for the lack of vulvar education in residency was to tell us, if you don't know what it is, biopsy it.
Yeah. Right. If it's white, take a bite.
Yeah. So, but now that I'm a vulvar specialist, I'm like, why would I torture my patient? Maybe I would just rather know what it is by looking. That would be a more efficient way to go about this. Yeah. So if you are listening to this and you are a new out of residency physician, or you're someone who's just getting into this space of like treating women with vulvar conditions, it is never wrong to biopsy it. I'm not saying that you should never biopsy it. I'm just saying that you don't always need a biopsy to make that diagnosis. I tell patients, because some patients say to me, well, you're not going to biopsy it. I read online, you have to biopsy it. I say, well, you know what? Here's the thing. So I can't give you 1,000% sure this is what this is, but in my vast experience treating this, I think this is highly likely that this is. We're going to try a treatment. If it doesn't help or it's not improving, then that's when I'll biopsy you. Or I say, if it looks suspicious for cancer, I would always biopsy it.
Yeah, I do the same. And then, sometimes when patients really want to know, and I'm like, if you really want to know, we can definitely do a biopsy. There's sometimes power in that for patients. And I tell them, like, okay, if you have this now on your medical record, you can, wherever you go in life, you can always, flash this biopsy to somebody and say, yes, this is what I have. So there is sometimes I think some power in that for patients if they want to have that information. But we see this a lot, so it won't change sometimes. And sometimes I think you and I both, we catch it really early. Yeah. And I'll have that conversation with patients where I'm like, I see these changes. It's really early. I don't even know if the biopsy would even tell us it's there. And so why don't we just go ahead and treat you? And then if it's getting better, great. And if it's not, then we'll look at some other options. And maybe then we do a biopsy.
That's actually one of the things I was going to say. I always wish that we had photos of what a vulva looks like 2 years before people are diagnosed or actually have like clinical evidence of lichen sclerosis. Because what I see fairly frequently is like some creases in the interlabial sulcus, yes. Right? That they may not even have the whitening yet, but these creases. And to me, my mind, that means inflammation. There's inflammation here. So is it yeast? So let's rule out yeast. Or is this the beginnings of a dermatologic condition like lichen sclerosis? Because there shouldn't be creases in between the labia majora and the labia minora. And so to me, it screams inflammation.
It should be this smooth crevasse with nothing in it. And you'll see this little subtle line. Patients might not even know it's there. They might not be complaining of pain or anything or even itching. But then sometimes I look, I'm like, do you have itching there? And they go, how did you know?
Right.
And they weren't going to even tell me. And you can see it. And I think for the love of God, this world should look at women in their menstrual cycle, because then I'll start even asking them, what are your periods doing? You're 46 years old and your periods are starting to be every 2 months. Like, this is now cueing me in even more these are, it's a whole picture when you look at these patients. And but
Absolutely.
that is one of those very subtle things that you'll see, and I will address it for sure.
Yeah, absolutely. I mentioned this before, but I would always recommend biopsying if it looks like cancer. So, when you have lichen sclerosis, it does increase the risk of vulvar cancer. The baseline risk of vulvar cancer in women is about 1%. So it's a pretty low risk. I don't see vulvar cancer very often, but it's something to be aware of. If you have lichen sclerosis, it increases that risk about 3 to 5%. I tell my patients, that sounds so scary. I tell patients if it's treated appropriately, like I almost never see vulvar cancer. Like the treatments for this basically put this into remission. It basically stops the changes. And I have some patients that come in when they're being treated and they're doing a good job with their treatment. And I'm like, I can't even tell you have lichen sclerosis right now. If you came to see me for the first time right now, I would not know that you have this. So I just want to put that out there when we say that like, oh, this increases your risk for cancer. It feels terrifying. I mean, this whole condition can feel terrifying, but it is a small increased risk. And really that risk is mostly there if we don't treat it. And when the clinical trials and they looked at who used steroids versus not using steroids, the risk was increased when people were not using steroids. So
yeah. Sometimes when patients come to see us and maybe they've had this for a while and they have scarring, it's important to tell patients when you use those steroids that I can't reverse what's already there. The steroids can't reverse it, but they can keep it from getting progressed.
Right.
That's the key with the steroids. And there's a big study in Australia. They looked at 500 women with LS, and they found that if you don't use steroids regularly, 40% had progression of that scarring. And then also that is where if you don't use steroids, that 3 to 5% cancer risk is. That's where we kind of quote that from. But this is something that's manageable. With use of steroids, which is the gold standard, you can get LS to look inactive. And I will tell patients that, we can get this to where it looks very inactive, but yet you're going to need to stay on some form of topical steroid as a maintenance for the rest of your life. And that's a hard pill to swallow, I think, sometimes for people because there is no cure for this condition.
So the treatment is using an ultra potent topical steroid, corticosteroid, and that feels really scary for a lot of people. We have this idea that steroids, you take them systemically, you gain weight, you have mood changes, you don't sleep at night, all these things, your blood sugars get out of whack. This is not oral, this is topical, so it's not systemic. I'd say the vast majority of my patients do not have side effects from using a topical steroid on the vulva. I generally have patients, if they're first being diagnosed, I have them use it every day for 6 to 10 weeks. It kind of depends. It depends on how severe I see their lichen sclerosis being. But I would say around 1 to 2 months, I have them use it every day. And that's because I really want to treat this as aggressively as we can. And then we could start using a maintenance to keep it there, which is just a couple times a week, like twice a week. Remember, you have to use this ultra potent steroid because we have to get through the skin to the part that's the thickened inflammatory part that's causing the scarring to be able to treat it. So if we use a lesser steroid, it will not work as well. And, the big thing people always say is, I'm just worried it's going to thin my skin. You told me my skin looks thin already. This feels terrifying. Meredith, what do you tell patients?
I think we need to know, what is thinning of the skin? And there's the studies to show that a lot of patients don't really know. It's a fear. And we don't do a good enough job showing patients how to use steroids either. And I know you and I both take the time where, I take a little piece of Vaseline and I put it on my finger, just this tiny, tiny amount. And I put my fist up and I said, my fist is no bigger than your vulva. And this little tiny lentil size amount of Vaseline can cover the whole backside of my hand. You don't need gobs of it to put down there. And these ultra potent steroids are effective in the areas that lichen sclerosis likes to live, in the labia minora and in that sulcus and around the clitoral hood, the perineum, and even the anus. And if those ultra potent steroids get outside of these areas, if you're using gobs and gobs of steroid, it gets on skin that can get thin from the ultra potent steroid. And that's kind of where that comes from, is what I tell patients.
Yeah. Yeah. And remember, we've talked about this in other podcasts, but that inner labia is pretty steroid resistant. It's that modified mucosal membrane, and it really is different than using it on your regular skin. So it's pretty steroid resistant. And ultimately, using these on a regular basis is not going to thin your skin in a way that is dangerous for you. It's going to treat your condition. But I absolutely think it's worth talking to your doctor or, talking to other women who have these conditions, because I know it does feel scary. Steroids aren't the only way we can treat this, but it is kind of the standard of care. First line is to use something called clobetasol. I definitely have other steroids I use. I really like mometasone and desoxymetasone. And so there's a lot of other ones out there, betamethasone, but as topical steroid is the main thing. There are other things. Sometimes we can use calcineurin inhibitors, things like tacrolimus. I don't use that all that often. It burns when you put it on the labia. So I really hardly ever use that.
Yeah. And my understanding is that hasn't necessarily been studied in cancer prevention. That's the other thing, because the risk is small, but it is there. Also, there's some promise, hopefully, in the JAK inhibitors that is coming out.
We did a clinical trial recently looking at JAK2 inhibitors on this. It's a different kind of medication that's a different kind of anti-inflammatory. I mean, the question is, does it help the condition, but also how does it change the histopathology? Like, is it really changing the underlying etiology of the disease on the vulva? So more to come on that. Hopefully there will be more research in this area. I just think if you're a person who's having a bunch of itching and you feel like no one's telling you what's going on, please make sure to go to a clinician that looks at your vulva. I think most gynecologists can recognize this. I think we do need to do a better job at training our gynecologists about this and how to treat it and things like that. But I think that most gynecologists can recognize this and then at least get them started on a steroid. But one of the common things that we hear a lot, that I see tons, and I'm sure Meredith, you do too, is someone diagnosed people and then gave them a steroid and said, use this for 2 weeks and then stop. So it gets better for a couple of weeks, but they were told it'll thin your skin. You can't use it long term. So if you stop, it will come back. So that's why you use it a bunch at the beginning, and then you have to keep using it twice a week or something on that forever.
Yeah. I mean, that's how we were trained. It was, oh, this steroid is so strong and don't use it for super long time. You're going to get resistance to it and it can thin the skin and all this stuff. Like, we were taught that. And so we were terrified to use it for a long time. When I went to my first vulva conference in 2019, I realized, oh my God, I was taught wrong.
Mm-hmm. Yeah.
and went back and these pages like, oh my God, you need to stay on this stuff. Like, this is really important. And so, yeah. And sometimes you just feel great when they're not using it. I'm like, I feel great. I don't need it. And then I tell them, like, this is why I have you come back every 6 months so I can look and we can revisit this so that like, I know you feel great, but you still got to use your steroid like a couple times a week.
Yep. And it's hard. Like, I mean, I can barely wash my face at nights before I go to bed. I'm so tired at night. So the idea of doing this twice a week, every week for the rest of your life sounds like a lot, but it really does almost erase your risk of cancer if you're doing that. And it really treats the disease and makes it not progress. The other thing I really like to have patients do is use estrogen on the vulva with this condition. I always say, like, they're a nice adjunct to the steroids because they really plump up the tissue, and it's not just in the vagina, it's like on the vulva. So I really think that's good for the tissue. So a lot of my patients are on an every other night situation where they, use steroid one night, estrogen the next night, steroid one night, estrogen the next night. I think that is a really great option for a lot of patients. Not perfect for everybody, but I do really like that. And then you brought up a great point. I do like to see my lichen sclerosis patients every 6 months because I do think someone needs to put eyes on the vulva every 6 months and see how things are going. And I also think it's a good reminder for patients that they should keep using their steroid, and it's because they know they have this appointment coming up, and a year is kind of long. And I think it's a bigger chance of not keeping up with it.
In addition to local hormone there and steroid, even using just other things to help kind of protect your vulva and soothe it with the emollients and barrier creams and things like that we recommend I think a lot of times, it's just like the serum for your face, but for your vulva.
Right. Yeah. Anything else? Any other pearls you want to say about lichen sclerosis?
Like we said, it's important to get regular exams because we do need to monitor. Are you responding to therapy? Are we seeing any functional changes where maybe you're having tearing and things like that? And then looking for cancer, obviously, if we see anything concerning for that, and if they need to have a biopsy. I think it's important in these patients too to just kind of check in on their mental health, because these things can be sometimes very isolating feeling, and it can affect relationships, and just making sure that mentally we're doing okay. And then, just bodily functions, urinating, bowel movements, sex, like these are things we need to also address in these scenarios.
Absolutely. And our next episode for this month, our deep dive into lichen sclerosis and lichen planus, we're going to have 2 amazing women that have support networks for people with lichen sclerosis. So there's definitely resources out there for people who are struggling with this diagnosis or struggling with their condition.
Yeah.
All right. The one thing I will also say before we jump into lichen planus is that lichen sclerosis, one of the ways we know the difference is lichen sclerosis never goes past the hymen. So it is not vaginal. It is only vulvar. So it will always be on the outside. It is never in the vagina. If you see white going into the vagina past the hymen, it is not lichen sclerosis. It does not go past the hymen. So
Agreed. Yes.
hard, fast rule.
So what does go past the hymen?
Lichen planus is a little bit of a tricky one. I'm just going to say it is not my favorite.
It's really hard.
It is hard. Lichen planus is, I think, hard to. It's a little trickier. Like lichen sclerosis is much more common. I see it more often. It is something you see more obviously. Lichen planus can be a little bit more difficult. It can present in different ways. There's different kinds. So it can be more erosive or ulcerations. It can be more white and lacy. It does go into the vagina. And so one of the things that sometimes can happen is that the vagina can actually agglutinate or kind of stick together because of this erosive tissue that's happening in there. So patients sometimes come in and say, I feel like my vagina is closing up. And they don't mean the opening of the vagina. They mean like you actually can't put anything inside anymore. And so this is another condition that, like lichen sclerosis, can be multiple places in the body. So a lot of these women have mouth lesions also. So when I'm looking at diagnosing the vulva, I'm like, oh, do you ever get sores in your mouth? But you can see this kind of lacy white stuff in the mouth sometimes also. And I have a patient that has pretty bad LP and she has it in her esophagus. Any mucosal membrane can have this.
Yeah. You might be like, oh, I'm having a problem in my vulva, but then also I can't eat spicy food or it's hard to swallow. These are things that we'll ask patients if they're having. I don't know about you. I'm not as good at looking in mouths, but I try.
Oh, mouths are gross. I know your husband's a dentist, but
yeah. But I mean, I look and I'm like, if I see something, maybe just, I'm like, that's what I send to my vulvar dermatologist because she's more adept at treating skin over the entire body, whereas I'm just focusing on the vulva.
Yeah. Yes. It is also autoimmune. So like lichen sclerosis, we don't know exactly why people get this, but we do know there's some autoimmune components. And if they have other autoimmune disorders, they're more likely to have this. I think that with lichen sclerosis, you can be in a remission if you're on treatment, but generally it's pretty chronic, where I think LP can be a little bit more kind of chronic and relapsing, where sometimes it's better than other times and things like that.
Mm-hmm. Agreed. And there's even sometimes some overlap. Like maybe you have lichen sclerosis and then you're getting more flares and it's kind of more inside, right in the vaginal opening. Then it's kind of, we go, oh, I think maybe we're starting to kind of cross paths a little bit. You do see that. And that's really challenging, but they can do that.
So symptoms you may have if you have lichen planus would be pain with sex. Obviously pain with sex can be a lot of different things. If you listened to our podcast last month, a lot of other things it can be, but this can cause pain with sex. You can have a vaginal discharge, especially if you're having erosions or things going on in the vaginal tissue. I already talked about the stenosis or like the changes in like the size or depth of the vagina, because that definitely can happen. And then sores. Some of these patients get these erosive plaques on the vulva that can be really, really, really painful.
Yeah. And that discharge can be tricky because sometimes patients, that's all they'll kind of have. And we're talking, this is copious discharge, like have to wear a panty liner, and can be irritating in the vagina. And patients will get so many swabs put in their vaginas to look for infections. And that's either coming back negative or there's something on it and they're getting treated and they're not getting better. And then we have to kind of put on our dermatologist hat and address this, because this is a dermatologic problem and it's from just massive inflammation in this vaginal tissue. And of course, that's going to cause that wet tissue in the vagina to just almost like it weeps. Like you just look at those vaginal walls and it's just like, it looks so inflamed and irritated. And that's where it's coming from. And there's a thought that this particular condition I'm talking about is something called discriminative inflammatory vaginitis. And there's a thought that maybe lichen planus and this are kind of related, but even LP just alone without the discriminative inflammatory vaginitis can create that discharge.
Yeah. I would say because LP can be somewhat variable in how it looks, it also can be more subtle, that it's just a harder diagnosis. So this will be a place that biopsy may be more helpful, especially if you as a clinician are unsure. I tell patients I biopsy if I think it's cancer or if I'm unsure about what's going on or my treatment's not helping. So those are kind of my things of why I biopsy.
Yeah. And sometimes the biopsies aren't always definitive in LP either, which is really hard. Like I have to really, using a pathologist that looks used to looking at skin all the time is always key, but really telling my pathologist, like, I really think this is lichen planus, and so that they can really kind of look at it. But there's a lot of times you biopsy it and you swear to God it's LP and it doesn't come back, and it's frustrating.
That's my other issue with biopsies is that, we were taught in residency, you biopsy and you'll know what it is. If you don't know what it is, you biopsy, they tell you. Sometimes they just tell you there's inflammation. And I think, wow, I knew that.
Yeah.
Like, I didn't need to torture this poor lady with a biopsy to have you tell me there's inflammation. I could tell that. So
yes,
that's the other thing about biopsies. They don't always give you an answer. And that's really why we do a lot of them.
Yeah. And LP could have a cancer relation, but
it's not nearly as much as LS though.
Yeah, which even LS is very little, but LP could.
How we treat this, a lot of times it's corticosteroids also. So because there's vaginal involvement, I usually have patients use a suppository, like a hydrocortisone suppository a couple times a week to help the vaginal mucosa. Because if you put something on the vulva, but you actually need to treat the vagina, it's not going to help. So they can use a steroid on the outside and something in the vagina as a suppository that will help with that.
Yes, agreed.
Some of these patients need systemic treatment. So this is where I feel a little out of my league as a gynecologist because we're not trained as dermatologists, as we've talked about before. So when they need oral suppressions, be it on methotrexate or hydroxychloroquine, something like that, that is when I send them to vulvar dermatology because I feel like they know these systemic meds. They use them all the time for the other patients who have like psoriasis and these other kind of more systemic conditions, and they are really good at this. And so that's where I usually send them to a vulvar dermatologist.
Especially if it's like bad mouth involvement, it's in my scalp, it's all these other places. Like you need to go see the derm for sure.
Yeah. So, I mean, it is a chronic disease like lichen sclerosis. You need to follow up with your clinician, whoever's treating you regularly. Putting the hydrocortisone in the vagina is really helpful to help prevent the stenosis and scarring. Sometimes I have patients put dilators in there too if they're not having penetrative sex just to keep that area open. But definitely, I think because LP is a little harder to treat, definitely having a team of, derm and GYN and maybe pelvic floor PT and maybe, if they're also having like esophageal issues or mouth issues, like experts in those fields too. It's a little bit more of a systemic disease in my mind than lichen sclerosis.
This is the Labia Logic, but with this particular one, like you have to look in the vagina as well.
The main thing about both these conditions is they sometimes can be hard to get diagnosed with. So if you're having problems that are, any of these symptoms, pain with sex, continual itching, changes on your vulva, it's really time to see somebody who knows what they're doing. Having someone look at your vulva and your vagina and do an exam is super, super, super important. You can't diagnose these over telehealth. You can't diagnose these over someone telling you their symptoms. These are something that needs to be evaluated in the office with an exam.
Agree. So what do you think kind of takeaways wrapping up with these two dermatologic things?
They're pretty different conditions. I think lichen sclerosis is a much more common condition, and it seems easier to treat to me than lichen planus just because of the systemic nature of lichen planus. If you're struggling with conditions like this, you need to see someone that can help you with this. And if you have one of these conditions, I don't want you to lose hope. I think these are both treatable conditions. It's about finding the right team that can really help you.
Yeah, agree. And like something I always tell my patients, because it's overwhelming and there's not a lot of information, but they're, telling them that we can get this into a better state for you to where it looks inactive. And I don't want your vulva to rule your life. Look at the big picture, address any sexual dysfunction and mental health, any hormonal issues, because these two both oftentimes like to jump out in the hormonal fluctuations. So maybe you're perimenopausal or menopausal or lactating, and making sure you get local vaginal hormones to address that in the tissue, and being there for them and telling them, I don't want this to rule your world. I want you to live a full life, and you will thrive, and let's get you on a maintenance eventually. And then this is just going to be part of your routine, and we're not going to make it take over your whole world.
Absolutely. Well, tune in 2 weeks for our next episode. We're going to be talking to 2 women who have advocacy platforms about lichen sclerosis, and they're 2 women who actually have lichen sclerosis themselves, and talk very openly about their struggle to get diagnosed, their path, and then why they have chosen to kind of help other women who have this issue. So please join us for that. But thanks for being here. We are here to demystify these things that happen on the vulva and the labia, and we're happy you're here for it.
Thank you for joining us. And if you want anything else for us to discuss, just leave it, on our Instagram or in any comments on our YouTube, anything. We're happy to discuss anything that y'all want us to talk about.
Yeah, and if you're loving Labia Logic, like I hope you are, feel free to give us a rating on Apple Podcasts or wherever you get your podcast, and a comment if you're loving it, or if you have things you want us to talk about. Thanks for joining us for this episode of Labia Logic.
We get it. Sharing a podcast like this might feel a little taboo, but we're here to break down those barriers. Labia Logic's all about empowerment, not embarrassment.
If you found this episode helpful, we hope you share it with others who could use a little Labia Logic in their lives. Can't we all? You can find us on all major podcast platforms and connect with us on Instagram at labia_logic.
From our lips to yours,
Viva la vulva!